Good evening, everybody. Welcome to this webinar on Docplexus. And I am Dr. Vipul Kapoor, Senior Interventional Cardiologist at CIMS Hospital, Ahmedabad. I did my MBBS and MD from Ahmedabad. And I did my DNB Cardiology from Care Hospital, Hyderabad. I've been practicing since 2007 in Ahmedabad. And I have my fellowship in European Society of Cardiology and Cardiology of Society for Cardiovascular Angiography and Interventions. I am primarily interested in adult interventional cardiology, including coronaries and peripherals, but real focus onto structural heart disease as well. But at the same time, academic focus has never dwindled. And these lectures are part of the joint international conference that we held, that we keep on holding every year. And the lectures that we are presenting now were actually part of this year's GIC conference. My colleague today is the senior interventional cardiologist and a senior colleague of mine, well-known interventional cardiologist, Dr. Milan Chugh. Who has been in the field since almost 40 years, and he did his DM from SDPGI and was the first cardiologist to do pediatric cardiology interventions in Ahmedabad. Apart from that, adult interventional cardiology, coronaries, as well as peripherals, as well as structural heart diseases, and of course has a lot of presentations as well. And he's also a fellow of the American College of Cardiology, and also is the part of the heart transplant program, which we are doing successfully at CIMS as well. And he has been part of the Lipid Association guidelines as well, which were published in 2017. So he will be my colleague today, and he will join us shortly if he has not yet joined, and then we can convene the show together. I think we can now move on to the presentations, I believe. Then we can have the questions later on at the end of the presentation.
We'll be starting with non-invasive evaluation for CAD. Pertinent question, and it has been covered partly in the previous lectures yesterday and today as well. So I'll just try and cover certain things more because quite a few people would have missed it. So we'll again look at it. So the basic crux of the lecture is formed by the latest European Society guidelines, wherein they looked at the diagnosis and the management of chronic coronary syndromes. So there are 5 steps basically, or rather 6 steps to actually, most of these patients are chronic coronary syndromes. They are stable CAD. So what do you do? Right? They have angina, they may not have angina, they may be totally asymptomatic, they may be relatively asymptomatic. So how do you go about it? What are the diagnostic algorithms? So what diagnostic steps you should follow? So first and foremost is always the clinical assessment of the patient, and that is how you form the pre-test probability and how do you go about it. So assess the symptoms, perform clinical investigations. Unstable angina, follow the ACS guidelines. If there are comorbidities, look at the comorbidities and the quality of life. Look whether the revascularization would actually help the patient or it would be futile. You can consider medical therapy. Resting ECG, biochemistry, chest X-ray in selected patients, echocardiography at rest, ejection fraction less than 50%, you go to the section 4th, and that is pre-test probability and the clinical likelihood of CAD. If you find that the cause of chest pain is likely to be other than CAD, then you can actually treat as appropriate or you investigate other causes. So these are the first 4 steps which actually define the pre-test probability of a patient who comes to you with a chest pain, whether he or she is likely to have coronary artery disease, or it is an atypical chest pain, or whether it is a non-anginal chest pain. And that is how you would actually go to the next few steps. So when we look at the guidelines, we look at 2013 guidelines, and when you look at the 2019 guidelines, because of the improved risk profiles and because of the improved pre-test probabilities and the improved risk scores, what they found was that in both men and women, as the age increased, based on the type of chest pain, they found that in 57% of the patients in 2019, vis-a-vis the earlier guidelines which are in blue, and when you look at the orange bars, which are 2019 guidelines, they found that the pre-test probability actually dropped to 15%. That means we are much better than what we were in 2013 in diagnosing or in assessing patients who come to you with chest pain to whether actually go for CAD evaluation and how to go about it. So what they did was that we have a chart here, and this is the chart wherein you put in the age, the gender, and the symptoms, right? So if you have a typical chest pain, male and women, men and women, age from 30 to 70 plus, and you can actually chart the profile based upon the type of chest pain and these three probable factors, right? So atypical, typical, non-anginal, and whether it is a dyspnea, which can be an anginal equivalent symptom. So you chart the criteria based upon the age and all these factors, and then you come to a probability. And if you have a pre-test probability, anything more than 15 to 20%, 25%, you know that the likelihood of CAD is much higher in this group of patient, right? And that is how you decide what test or further test that the patient needs to undergo. So determinants of clinical likelihood of CAD based on the sex, age, and the nature of symptoms. So what will decrease and what will increase? So decreasing by way of a normal exercise ECG, no coronary calcium by the CT, that is the Agatston score of say 0, which was just touched upon in the previous lecture. What would increase the likelihood would be the risk factors, the classical risk factors for CAD, whether there are ECG changes at rest, whether there is LV dysfunction, which is suggestive of a CAD, whether there is an abnormal exercise ECG, and whether there is a coronary calcium. So if you classify the patient into these two criteria, look at the probability, and then you decide what further test that needs to be done for this particular patient. So completing the 6 steps, right? So we looked at the 4 steps earlier. Now let us look at the 5th and the 6th steps. Suppose you find that the probability is very low, there is no diagnostic testing which is indicated. On the other hand, when you look at intermediate probability, you decide on the choice of test which can be good for the patient, and here you can perform a coronary CT angiography for the intermediate risk group of patients. And then if you find that again the CT is possibly suboptimal or indeterminate, then you can go for functional testing like your stress echocardiography or CT FFR if it is available. And if the patient is in any case very high risk, then it is very simple. You have to straight away go for invasive angiography with or without your functional imaging, that is your FFR or IFFR. Right? And then you can choose the appropriate therapy based upon the clinical profile of the patient and the event risk that this particular patient would have in the near future. So it is very clear that if you have a low risk probability, then you can possibly go for a non-invasive testing, and then like a stress ECG, like your treadmill test. If you find that it is strongly positive, you can either go for a invasive angiography or a coronary CT. Invasive angiography group for high risk patients, again, if it is very, very clear stenosis is more than 90%, suits with your clinical risk, go for revascularization. If still not, functional assessment, and if it is normal or subcritical or non-critical, you can go for drug therapy. And then if the symptoms develop, then you can go for revascularization. So what basically is important is that you have to actually move from the low risk probability. You have to move the patient. So if the stress ECG is indeterminate, the performance of the test is likely, you have to decide to rule in or rule out. So if the stress ECG is negative, the ischemia probability is more or less ruled out. If it is indeterminate or strongly positive, then it is ruled in. So therefore these tests like PET or CC angiography or coronary angiography, CT angiography would actually help you in deciding to rule in or rule out CAD. So let us look at what are the ranges of clinical likelihood. When you look at your stress ECG treadmill, it is very good at ruling out the presence of CAD. So when you look at the green chart, this is actually ruling out CAD. So it is as good that the pre-test probability, if the stress test is negative, then the pre-test probability is actually less than 15%. So it is very at ruling out. If the stress test is borderline, then the possibility of ruling in CAD it is false positive is quite high. But if it is strongly positive, then again the specificity is pretty high. That we clearly know about stress echocardiogram or the stress ECG. So exercise ECG thereby is recommended for the assessment more for exercise tolerance, look at symptoms, arrhythmias, BP response, and event risk. So rather than to rule in ischemia, it is now the indication for this is more for looking at these particular aspects of the patient rather than to rule in ischemia. And that is where now CT angiography has taken in or has come in if the facility is available. For patients who have very clear evidence on ECG, stress ECG, then you should not do the stress TMT or the TMT test or the stress ECG. Straight away go for some form of angiography, and it is class 3 recommendation. So these are all the tests that have been put forward, and you would find that stress CMR, stress echocardiography, they have pretty good sensitivity and specificity to rule in CAD, and to see that where there is a clinical likelihood of FFR, whether it is functionally significant, you would find that invasive angiography is not still very good, but look at PET and stress CMR, they are better for functional significance of a block, wherein you require some form of physiology testing like CT FFR. Okay, so what is the probability? So if you find that the exercise ECG is is strongly positive, then cardiovascular mortality is more than 3%. These are different probabilities and positive values of different tests. When you look at SPET or PET perfusion, if the area of ischemia is more than 10%, then it defines high rate. So what is high risk based upon these tests is what is shown in this chart. Stress echocardiography, if you find more than 3 of 16 segments, then it suggests that it is high risk. CMR, more than 2 of 16 segments or greater than or equal to 3 dobutamine induced dysfunctional segments, then it is high risk. Coronary CT or the invasive angiography, if you find triple vessel disease, proximal stenosis, left main disease, proximal left anterior descending disease, then it is high risk patient. Invasive functional testing, if the FFR is less than 0.8 and IFR, if it is less than 0.89, then it means high risk patient. And that is how your therapeutic approach should be tailored depending upon high risk, low risk or intermediate risk. Let us take a case example. This is a patient with chest pain, and she has chest pain, and which is a bit atypical. So the age is 66 years. She is a female, atypical angina. Family history of CAD is strongly positive. Chest pain is there, 2.5 millimeter ST depression in inferior leads, heart rate of 164, METs of 7.4, LDL is 116. So no hypertension, non-diabetic, no smoking. So if you look at our first slide and you look at the probability of this patient, there are 3 positive factors. She has dyslipidemia, family history of CAD, but there is an atypical chest pain and there is abnormal ECG. So the question to you all is her risk profile according to this chart is 11% based upon her age, symptom, atypical, and the risk factors that she is a female. So the question here is that what do you do for this patient with stress? Would you do anything? I will not do anything. Primary prevention, I think you can have the voting meters. No more information to make the decision. Would you do an exercise ECG, a CT angiography, ischemia imaging, or coronary angiography? So time starts now. So most of you say CT angiography, which is fairly okay, but because this patient is 66 years, strongly positive ECG, we decided that we did an invasive coronary angiogram, and this was the outcome. She had a significant disease in the diagonal artery. Now, whether it is functionally significant or not is a separate issue. What we did for it was, again, say an FFR, because this was fitting into something where the invasive coronary angiography showed a block, but whether it was functionally significant or not, we did an FFR and found that it was not significant. And ultimately, we prescribed medical management. So that is what the gist of the lecture was, that we try and risk stratify the patient, decide what is good for the patient. If the patient has intermediate risk on your CT angiography, then you look at the clinical risk profile and then decide whether she or he needs invasive angiography or medical management. I think that is it. I think I'll just stop here. Thank you for your kind attention. So lipid updates, implications for clinical care. So an important topic, practical topic, and I believe every one of us are, adept at treating most of them, but there are still certain doubts, certain misconceptions that still remain, that do remain, and I will try to, take them off. So moving on to the case. So let us look at a couple of cases. So this is our first case. She was a female of 57 years old, acute inferior wall MI, 3 hours onset. First episode of ACS, no history of hypertension, diabetes, and basically never had a lipid check like most of us do. So these are the ST elevations that you can clearly see, inferior wall MI. This was her angiogram. As you can see, this is the right coronary artery, totally occluded. And left main circumflex LAD had no significant lesions. So this patient underwent an angioplasty, primary PCI was done. The result was good, as you can clearly see here. What about the lipids? What about the lab result? So on day 1, her labs were done. As you can see, most of them were pretty good. HbA1c of 5.8, so non-diabetic. Look at the lipid profile here. And if you look at the LDL and the total cholesterol, you can see the HDL is pretty good. The triglycerides are fine, but very high total cholesterol and LDL. Okay, so 247 by any standards, any figment of imagination, they are pretty high. So we do, what was the in-hospital follow-up for this patient? Patient did well, had initial runs of VT in the first 24 hours, but they were spontaneously terminated. The ejection fraction was good. The global ejection fraction was good. RV function was good. Patient was discharged on day 4. What were her discharge medications? Aspirin 75, ticagrelor 90 BD, atorvastatin 40 milligrams, ramipril 2.5, bisoprolol 1.25, amiodarone 200 milligram BD for the time being. So apparently the treatment looks fine to most of us. This was her outpatient follow-up. The patient went home, pretty good. 1 month follow-up. This was the baseline in-hospital lipid profile that we just saw. 1 month, 50% reduction, that is what we do think so. The LDL came out to be 138. So you can see that the 50% reduction was not achieved with atorvastatin 40 milligrams, though it was well tolerated. So what was done? The atorvastatin was increased to 80 milligrams. 3 months follow-up, the patient goes home, comes back after a couple of months, and the LDL is almost the same, has not come down. That means the goal of say 55 milligrams is not achieved. The dose increased to 80 milligram was already increased at this point, and still this was not achieved. So what was done? Ezetimibe was added, 10 milligrams over and above atorvastatin of 80 milligrams. So the question here is, if you have your voting pads ready, we'll vote here. Do you think the LDL, the cholesterol lowering regimen practiced here is appropriate? So I think the time starts now. How many of you feel yes? How many of you feel no? I think you can vote. People who have got the voting pads, I think they can vote. So let's see. Okay, so we are even Stevens. And most of you, it's a split verdict. Both the answers are, equivocal. So obviously it means that we are still, not very clear. But let us look at the guidelines as well. And what do the guidelines say? So just a quick snapshot, and I will present you the latest guidelines which have been put in. 2019 ESC dyslipidemia guideline. So without contraindication, high dose statins, class 1A. So 40 milligrams of, say, high statins. So if you see rosuvastatin, 40 or 80 milligrams of atorvastatin should have been in the first place itself. High dose, re-evaluated at 4 to 6 weeks, and the goal should be to get it below 50% of the baseline. Right? So get it below 50% at least, and for a patient who has had an ACS, it has to be dropped below 70, ideally below 55. So it is 2A, level of recommendation C. And if it is not achieved after 4 to 6 weeks, then ezetimibe. So part of which we were correct, that that the regimen was still okay, but then it was still inadequate because the goal was not achieved. And that means we needed to do a bit more. So let us move on to the next case, and then we'll move on to the guidelines. So this is a 60-year-old asymptomatic. This is the other spectrum, wherein the patient is not yet symptomatic, an asymptomatic male patient. He presents for a routine follow-up concerned about the potential need for a statin therapy. Right, so this is the most commonly asked question to most of us. Hypertensive, non-diabetic, non-smoker, no family history of premature CAD, and apparently following a healthy lifestyle. Physical examination, unremarkable, BMI of 30.5, so you can say overweight, to a degree obese. Blood pressure of 128/78. These are his lipids. Total cholesterol 206. LDL of 124 milligrams per deciliter, HDL 48, triglycerides 164, fasting blood glucose of about 114. So you can see an impaired fasting glucose level here, borderline elevated triglycerides, cholesterol and LDL. LDL, if you look at, apparently below 130, so fairly good. Now, after discussing the potential role of a statin, given an estimated 10 years, so his ASCVD risk score was 10.6%. Okay, over the period of 10 years, the patient was still very concerned. So you do a risk profile for the patient. You tell the patient this is your risk. The patient thinks that he's still bothered whether he'll have a CAD event in the future. He has not, but at the same time he's worried because most of the anecdotal reports, most of the research papers, quite a few of them have showed that statins have negative effects, particularly when he has an impaired fasting glucose, regarding cancers, potential for diabetes. So this patient is concerned. What would you do to allay his fears? Right? So what would be your next step in the management of this particular patient? Would you order a stress myocardial perfusion? Would you go for ischemia hunting? Would you do a coronary artery calcium scan? we'll have the voting pads, okay? Start statin despite patient objections. As you think that he is high risk, 10.6 more than 10 is a high risk. Increase diet and exercise and have the patient return in 3 months. So these are your options. Let us vote. So most of you think diet and exercise should be a good option for him. Nobody thinks a stress myocardial perfusion, which is pretty good. So 30%, around 30% coronary artery calcium, and the other things, other people think statins. So this is again a divided house, but most of you feel that diet and exercise is a good option. Okay, so let us see how CT, how does CT scan. Let us look at the guidelines. So let us look at what is the background and rationale. What are the treatment targets? We'll come back to the answer in a few slides from now. What are the pharmacological options and what are the changes that have happened in the new guidelines vis-a-vis the older ones? So if you look at the guidelines, the intensity of LDL therapy should be based on the risk. That is the most important point we keep on telling our colleagues. Look at the overall risk of the patient. Don't look at the LDL values per se in people who are asymptomatic, who have just walked into your OPD after a routine health checkup. Okay, look at the baseline, then you look at the baseline LDL cholesterol, and then whether lower is better, and if lower is better, then how much lower is better. Should you get down to 70? Should you get down to 55? Should you get down to 40? Right? So that is what we will look into in the few slides. So now the evidence, what is the source? CTT meta-analysis, Improve It, Fourier, ODC, all of them have shown that with mean reduction in cholesterol to great levels, you can actually reduce most of the outcomes, which include CHD death, total mortality, and you can also reduce the coronary events in the future. So what are the treatment targets in relation to the risk? So very clearly, the risk profile has been established as far as patients who are low risk, moderate risk, high risk, and very high risk. So based upon the criteria, whether there is a documented ASCVD, whether there is diabetes with target organ damage, CKD, family history with familial hypercholesterolemia, these are patients, or risk score of more than 10%. These are very high risk patients. That means your target has to be 55 milligrams per deciliter or lower. So it is unambiguous. There is no doubt about it. Similarly, low risk, that means the target of about 116, less than 130. The risk score is very less. The patient falls into low risk. Right? So the problem will come in the low risk and possibly moderate risk patients. For high risk and very high risk, the targets are very well defined. You know very well that statins have to be prescribed and the targets that you have to get down the LDL to. But these are the people where you need to evaluate and wherein you have to decide whether you need to prescribe statins or not. So the risk is something like this. So if you go on reducing from low to very high, if you reduce the level to about 55 and below, your CV risk also declines almost linearly. So that is very, very important. So there should be no doubt about the high and the very high risk group of patients wherein you should prescribe dose of statin at the right possible dose. And if the targets are not achieved, then add ezetimibe. And in the end, if the goal is still not reached, then consider adding PCSK inhibitor. So in the first group of patients with ezetimibe also, if the risk had not come down, LDL levels had not come down, you should consider adding PCSK9 inhibitor to that particular patient. So these are the recommendations, ezetimibe and then PCSK9. So the guidelines have incorporated 2B and C, consensus opinion, and it may be considered, PCSK9 inhibitor may be considered if cost permits. What about LDL lowering 2? Again, look at combination for PCSK9 for secondary prevention at very high risk, 1A, very high risk familial hypercholesterolemia, statin, ezetimibe, and PCSK9 is 1C. So familial hypercholesterolemia is a very high risk group of subset wherein you can consider should consider rather PCSK9 inhibitor. And if you can't tolerate a statin, ezetimibe should be considered if you can't tolerate statin to any dosage. Statin-based regimen is not tolerated, PCSK9, 2BC, and again, if a statin combination with bile acid, if you still can't achieve the goal, then you can consider a bile acid sequestrant. So what about triglycerides? So if more than 200 but less than 500, statins would be the first drug of choice. But if more than 500, then consider omega-3 fatty acids, and that too icosapent-ethyl 2 grams, about 4 grams per day. So the class of recommendation is 2AB, should be considered after the Reduce It trial that was just published. So summary of the guideline changes that we have already seen, target of 40 milligram. If a patient of ASCVD on statin but has second event, the target is less than 40 milligrams. For very high risk, 50. So the lowest is 39. So for every 20 to 25% reduction, for every 39 milligram deciliter decrease in LDL cholesterol, if you get them below 40, there is a 20 to 25% reduction in cardiovascular risk. So basically, these are small changes, but ultimately we have to take the leap. Many small people who in many small places do many small things can alter the face of the world. So I believe that these small changes that you do in your daily practice will actually help us in modifying the risk of our patients. To conclude, statins remain a mainstay in reducing cardiovascular risk. The addition of ezetimibe provides further LDL cholesterol lowering. New lipid guidelines endorse lower LDL cholesterol goals, particularly for patients with very high ASCVD. Only 1/4 of very high risk patients actually achieve. That means we need the additional LDL lowering with either ezetimibe and or PCSK inhibitor. So my friends, do not be afraid of prescribing high dose statins in patients who actually need it, and don't be lethargic in considering additional options like ezetimibe or PCSK9 inhibitors in patients who actually need it and who are not reaching their LDL goals. And for asymptomatic patients, risk stratify the patient based upon the total ASCVD risk and then decide whether giving a statin would actually help him or not. And CT calcium scoring is an important tool wherein asymptomatic patients in dilemma whether to give statin or not will actually help you in starting risk profile of statins vis-a-vis not giving statins should be considered. Thank you.
So I think we have listened to the two lectures that were scheduled for the day. Both were clinically very, very important and relevant topics. And I believe most of you would have, gained a lot of insight into these topics. We have a few questions. Has Dr. Milan joined the show, or I think he's not there? So I think I can address the questions that have been posted here. So we can begin with the first question. And what are the characteristics of a patient to be an ideal candidate for non-invasive diagnostic tests? So I believe any patient can be there is nothing like an ideal candidate. Basically, all patients can undergo. So the basic importance of non-invasive diagnostic techniques are that they are basically the basic advantage is that they are non-invasive, right? So any patient can undergo. It is just the modality that you have to choose, right? Suppose a patient is of osteoarthritis, cannot run, cannot walk, cannot exercise. Obviously, you can't subject him or her to stress ECG, right, or an exercise ECG, right? So you would obviously think of other modalities, like say possibly stress echocardiogram or a stress MRI, right? On the other hand, right, you can nowadays that now most of these modalities are now available. So you can obviously nowadays consider CT coronary angiogram, which is an excellent tool to risk stratify intermediate risk patients, right, and to anatomically define the disease that he or she might be having. So if you have the facility, if you have the no cost issues, then possibly you should have a very low threshold for CT coronary angiogram. So basically, there is nothing like an ideal candidate. All of the patients can undergo non-invasive. It is just the modality which would be ideal for that particular patient that you must choose based upon the overall risk stratification, based upon your clinical examination, based upon your preliminary reports that have come in, that includes your lipids, that includes your ECG and the baseline echocardiogram. Okay. Next question is internal follow-up care or routine screening that should be done to avoid complications. So obviously, post-interventional patients, I believe follow-up, they have to be as and prescribed by the treating clinician or the interventional radiologist. Follow-up care basically includes both medical as well as non-medical, and that basically includes your diet and exercise, which being a part of the regimen, have to be a part of the regimen, with a big focus on rehabilitation. Apart from that, routine screening. So care, apart from that, medical medications, obviously. So medications prescribed have to be religiously followed. And apart from that, screening. So routine screening is decided upon, based upon the months of follow-up. So obviously, as I said, as I showed in one patients, that once has occurred and you have an intervention, so you repeat your lipids after 4 to 6 weeks, okay, and look at the lipid targets and whether your medications have achieved those targets or not, and also whether the patient has some side effects related to that particular medication. So you not only check your medications, look at the symptoms and signs that you might see in clinical examination. You look at the lipid reports. If the patient is a diabetic, you look at your HbA1c levels. You look at your sugar levels, and then you tailor the therapy. Right? If the patient has LV dysfunction, whether the patient needs an ARNI or not, whether you need a diuretic or not, whether what about the salt and the fluid intake that you need to advise and monitor. So those things, weight of the patient, has it increased or not, whether it is there or not. So all of those things basically go into the routine follow-up care and the screening that we do. So it may be ranging from an ECG, it may range from an echocardiogram, it may range from a lipid test, right, or an HbA1c or a sugar test. So basically, these are the routine screening tools that we usually employ, right, and guide the patient and advise the patient on the next follow-up, and then possibly what tests would be required on that follow-up. So basically, whether the follow-up is required within a month, whether the follow-up is required within 3 months, 6 months. So that would depend upon the first follow-up, which we usually do about 4 to 6 weeks from the index event. Okay, so I believe that answers that question. Moving on to the next question. What are the potential benefits of non-invasive techniques over the conventional diagnostic techniques? So obviously, the first and foremost, by conventional diagnostic techniques, I believe it would be an invasive, is what I believe this question means to ask. And I believe the major focus, because echocardiogram and ECG are also mean non-invasive only. So the basic potential. So the first benefit, as the name suggests, the patient, doing those tests on a patient basis, very, very big. Okay, so that I believe is the first potential benefit of non-invasive diagnostic techniques. Okay, but at the same time, you have to be very clear in which patient you are ordering those tests for. Okay, because non-invasive, just for the sake of being non-invasive, doesn't mean that that test is ideal for every patient. So a patient who already has an ACS, who has an unstable angina, non-STMI, or even frank ST elevation MI, obviously you are not going to advise a CT angiogram, right? This patient obviously needs an invasive coronary angiogram, right? On the other hand, a totally asymptomatic young individual who just comes for a health checkup and then walks into your OPD for a cardiology opinion for a borderline high LDL, obviously you won't advise an invasive coronary angiogram, right? So you would obviously advise him non-invasive tests if they've not been done, like say a treadmill test. He's worried, so a treadmill test possibly, right, or an echocardiogram. And suppose you find that there are few risk factors, like say positive family history, he is a smoker or something, right, has some degree of vague chest pain, then you may consider a non-invasive angiogram. So based on non-invasive CT angiography. So basically, the basic advantages on an outpatient basis, a non-invasive test. Convincing the patient is a lot easier. So you just justify what test is indicated in which particular patient, and then order that test for that particular individual. So I believe those would be the potential benefits of non-invasive techniques over the conventional diagnostic techniques. Okay. Moving on to the next question, I believe this is a clinical case scenario. A patient of 66 years, old history of quite some time back of a cerebrovascular accident, underwent a triple vessel angioplasty, that too 4 years back, basically asymptomatic right now. Hypothyroid on eltroxin 75 mics, bisoprolol 5 milligram, sulfonylurea, glimepiride 1 milligram, and rosuvastatin fenofibrate combination, and ecosprin 75 milligram once daily. So blood reports are within normal limits, is what is mentioned. We do not know what limits the question means. Okay, because as we just listened in that lecture that I presented, whether it is triple vessel angioplasty means basically high ischemic risk burden. So possibly the patient requires intensive statin treatment and maintaining the targets at least below 75 and preferably around 55 milligrams per deciliter or 55 to 70 in between. So echo is normal, so non-infected territories. So what else should he do to cope with general weakness and faster movement or works? So basically, any general question, the patient is asymptomatic cardiac wise, and the only problem as per the question is basically weakness, feeling weak. So I assume that, the statins that they mentioned is stat or F, means it's basically 10 mg combination, and fenofibrate would be 160. So whether it is medication related, which is unlikely because statins at 10 milligrams usually do not cause any problems, major problems, but we do assume it depends upon patient to patient. So you look at the clinical status of the patient and then work out whether what is causing him weakness, right? And lethargy or lassitude as mentioned in this question. So whether it is an organic problem, whether it is medication related, right? And then address the situation accordingly, right? So if suppose it is due to a medication, like say possibly statins, right? And then possibly you can look over what options do you have now, because you need to give him statins. So what else can you think? So you can possibly stop for some time, re-challenge with statin, right? Consider stopping fenofibrate and putting him on, say, saroglitazar or even ezetimibe and statin combination, or you can even change the statin to others. Say, look at this is basically stator, right? So basically atorvastatin, you can consider pitavastatin. So that all the options you have. So if it is medication related, if not, then you can consider adding vitamin supplements, red coenzyme Q10 or something like that. So what exactly the problem is due to is what you need to address, and then accordingly treat this patient accordingly. Okay. Now, what is the role of lipid profiling in the risk assessment of CAD? Okay, now obviously, as we listened in the two lectures, particularly the second one, you can see that lipid profile does form an important test in the risk assessment of CAD. So obviously, patients who are low to intermediate risk, right, the absolute value of the LDL cholesterol does matter. So if their LDL cholesterol is straight away more than 160 milligram per deciliter, then that warrants prescribing him statin. Okay. Anything lesser than that, then you look at the overall risk profile of the patient and do a risk score, right? Based upon the different risk scores available, like the Q3 risk score, like the ASCVD risk score, the WHO risk score, right? So there are so many risk scores which are available online, right? And you can consider those risk scores, put in all those values in, and then find out what the risk profile of that patient is. If the patient, as is mentioned in the second presentation, if the patient falls into the high risk or the very high risk category, then obviously he or she requires high dose intensive statin therapy. If they fall into intermediate risk category, right, then you can consider risk profiling, better risk profiling, like say he or she may require a non-invasive CT angiogram, that is a coronary CT angiogram, to look at the actual presence of disease, right, and then to prescribe him statins or not. Low risk category, right, then you can possibly at values less than 160, you may just try diet and exercise as the first line of therapy and not consider statins at all. But first and foremost, look at the risk profile of the patient and then decide whether he or she requires statin management or lipid management or not. Okay, so lipid profile does carry a very, very important role in today's scenario, right, for CAD evaluation. Now, how to manage heart diseases in patients with high lipid index? I believe that has already been addressed in the discussion that we just held, right? So basically, heart diseases in patients with lipids, so the management doesn't change, right? It is just the dosing of the lipid therapy, right, that you need to monitor, and the drugs that you may use for the lipid management, right? So the targets and the drugs, right? High intensity statins, plus minus ezetimibe, right, plus minus fenofibrates, and plus minus PCSK9 inhibitors, right? So basically, heart disease have to be managed in the same way that we do manage, right? MI management doesn't change, whether the patient has a normal lipid or whether the patient has a high lipid, right? So it is just that the lipids need management, right? In the post-index event, in the post management scenario, that is where you need to monitor your dosing and the agents that you use for lipid lowering. Okay, next question is interesting. Atherosclerosis plaque begins in childhood, but it grows slowly over decades. So do you recommend statins in non-symptomatic adults? If yes, then at the age to start. Now, there have been a lot of studies, right, in the European and American countries. We do agree atherosclerosis begins right from birth. Okay, but obviously plaques do develop over a period of time. I firmly believe, and we have had this discussion quite a few times, and we all know that eventually all of us will require statins. It is just a matter of time when and at what dose and which agent which we all need, right? So the earlier you start statins, the greater the benefit, the duration of benefit that you would have for a long period of time as far as cardiovascular events are concerned is enormous, is immense, right? So the point here is asymptomatic adults. We have already discussed this, that based upon the risk profile of the patient and certain tests that the patient might require, like say CT angiogram, right? Certain what the value of the cholesterol is, what pattern of dyslipidemia that the patient has. If it is a familial hypercholesterolemia, it falls into a very high ASCVD risk. Family history of CAD. So all these things, right? Smoker, non-smoker, all of these things would define whether that particular patient requires a statin therapy or not, even though he may be asymptomatic. Okay. So, and then what age to start? So guidelines clearly mention that you may start as early as in adolescent or high adolescent age. So basically anything roughly about 25 years of age, 20 to 25, that is young adults basically, and beyond adolescence. So very high risk you may consider even in adolescence, but if the patient falls into that intermediate to high risk category, then you may consider starting statins, right? Even though asymptomatic, right? Then roughly beyond 20 to 25 years of age, as that early you can start statin therapy. Okay. And I believe the last question is that typical, part kind of a myth or a misconception that I would like to say. Statins are said to damage liver and LFT become high. Also, statins increase diabetes in high doses. What is your experience? So in these many years of my clinical experience and the discussions that we have been having this for quite some time now, there have been just a few case reports and anecdotal reports and non-randomized studies that have basically shown that statins cause diabetes in high doses. It is not that. It has been clearly shown that the potential to cause diabetes with high dose of statins is far less than the benefits that those particular statins would cause to those patients. It is just that these patients are possibly, when you started statins, they were in their pre-diabetic stage, and eventually they were destined to develop diabetes in the years to come. It is just that you gave statins and eventually you notice that the patient developed diabetes. But if you had not given statins also, then eventually they would have developed it. So what is important is that the risk profiling of the patient is very important. So if you find that statins are indicated for CAD prevention or CAD treatment, then don't deny those patients the statin dose and statins that they need, because the benefits far outweigh the risks that have been mentioned. Okay, so that I think is fairly well answered once and for all. And said to damage liver. So it is nothing like a liver damage, but yes, right, patients who possibly or probably already have a pre-existing liver disease or have some form of ongoing viral hepatitis or something, as well as some asymptomatic liver disease patients, or who may not have a liver disease, right? Some elevation of AST and ALT liver enzymes are definitely possible, right? And that is why when we call the patient at 4 to 6 weeks, right, or say 3 months, right, down the line, we always monitor that SGPT, that AST, the liver enzymes, right? And if, right, along with the patient also has symptoms, then definitely you need to modify the statin dosage, even stop the statins for some time, re-challenge them with a lower dose, right, or even change the statins to a certain degree. So yes, liver enzyme elevations are definitely possible, right? But if they are not 3 times more than the upper limit of normal ULN, right, of these liver enzymes, then and if the patient has no symptoms, then you may still consider giving them statins, because as I said, their benefits far outweigh their risks. Okay, but if there are dangerous elevations, the patient also has symptoms, pre-existing liver disease, be very careful. And particularly in patients in whom you give statins in combination, right, with say fibrates, then the chances of liver enzyme elevations are much higher. And that is why liver as well as kidney enzymes, our kidney values like say creatinine and urea are also important, and you do monitor them, right, after the index event 4 to 6 weeks, and then subsequently, right, at 3 months down the line, you monitor their SGPT and your creatinine levels, right, in patients in whom you suspect that they might have some elevations of or high risk subset of patients wherein liver enzyme elevations or kidney value elevations might be existing. So there you must be very, very careful. Okay. I think we have answered all the questions in fairly good detail. Kritika, I think that's okay. So, okay, a few questions as well. Statins increase the risk of diabetes. I think we have already answered that, right? Is there naturally occurring statins in food? Right, a few foods that have been shown, plant-based foods that may contain, statin-like compounds have been defined, and they are available, on the net as well. And you have got, cholesterol-lowering foods which have already been, like say garlic and all. So they have been already shown, onions and garlic and substances like those, as well as phytonutrients, right, and certain compounds that have been there and been published and being even the chia seeds, so certain seeds as well. So they have been marketed and sold as nutraceuticals, and I believe they do have the potential. But obviously they in high risk subset of patients, right, and in patients who have had a coronary artery event or a cerebrovascular event, right, in those patients obviously they can't replace statins, right, per se, but they can be useful adjuvants or adjuncts to therapy, wherein, right, you can actually cut down on the dose of your pharmaceutical agents, right, allopathy. You can cut down on those so that you can possibly have that added benefit. So obviously you can't replace statin in indicated patients, but you can definitely use them as adjuncts and adjuvants, to supplement, right, your statin therapy, and eventually gradually cut down on the dose of statins. So as I said, diet and exercise form an integral part of any, right, who has a coronary artery disease, subclinical, clinical, right, or asymptomatic patient, right, or person, right. They are an integral part of the therapy and simply cannot be excluded from any regimen at all, right. So therefore there are naturally occurring compounds, right, they do help, right, fish, omega-3 fatty acids and all, so they do help definitely, right. So but if statins are indicated, use them as supplements. Okay, I think we have answered all of the questions, and I believe it was a very fruitful and was a nice session that we had. Thank you all, for attending this meet, and I believe we'll have many more such meets coming up. And I thank the Docplexus, team for setting up this good, excellent webinar. And if there are any personal questions, we'll be readily, there to sort them out as well. Thank you, and take care and stay safe.